Well, good afternoon. It's 12:20, so we're starting a couple minutes late, and I want to thank you all for recongregating in here again, and thank our web viewers as well. This afternoon we have a very exciting agenda, and I'm thrilled to be here right now on the stage with some real rock stars in state policy. We heard a lot about how to advance the telehealth agenda at the federal level, and we also heard reference in many of our presentations about what the states can do, because so much falls under the state's purview. States play a major role in terms of state statutes, state regulations, state health reform initiatives. They deal with licensure, reimbursement, Medicaid, credentialing and privileging in some cases as well. And so I am really thrilled and honored to be here this afternoon with some colleagues from the Mid-Atlantic region, actually. So I want to briefly introduce our panelists. We have Cindi Jones, who is the Director of Medical Assistance Services for the Commonwealth of Virginia. And on behalf of Secretary of Health Bill Hazel, she chairs our Virginia Health Reform Initiative. We have Herrera, Dr. Laura Herrera, who is the Chief Medical Officer for the Maryland Department of Health and Mental Hygiene. And Maryland just recently passed a sweeping bill as well, hopefully becoming more sweeping as time goes on. We have Delaware Secretary of Health and Human Services, Rita Landgraf, who is herself a champion and convert, and who previously also worked for AARP. You were the president of AARP Delaware, and she's played a huge role in advancing services for the underserved in a host of different areas. And then last but certainly not least, Maurita Coley, who's here from the Minority Media and Telecom Council. They are a policy group that advocates for underserved and disenfranchised, and have done a lot of work in the telecom space, and also works closely with the National Organization of Black Elected Legislative Women, who themselves have now become devotees of telehealth. And so Maurita will also talk to us about how to advocate and to engage our states in terms of advancing our missions. So with that, I'd like to welcome Cindi Jones to the podium.
Good afternoon. I'm proud to be from the Commonwealth of Virginia, which is where Dr. Rheuban originates. We call her, or at least I do in Virginia, the Mother Teresa of telehealth. She's been very committed to moving us, both in the commercial arena as well as in Medicaid, of thinking of not telehealth as an afterthought, but an integrated, very important aspect of everything we do in terms of delivering health care. And I do actually have the privilege of wearing two hats for the state of Virginia, so I thought before I went into my staff presentation that kind of walks you through how we are implementing telehealth over the years in Medicaid, that I would tell you from the governor's perspective. When he came into office, he realized that, healthcare reform, there's lots of things to do that are even beyond what was in the Federal Affordable Care Act. So he created an advisory group of healthcare leaders, business leaders, to kind of talk about what we could do better in Virginia in 6 strategic areas, which were payment and delivery reform, capacity, access as it relates to the doctors, technology, Medicaid, insurance, and then how you get employers involved in moving the ball forward for value-based purchasing. And as you can tell just from those topics, telehealth was intertwined in all of them. When we talk about the payment and delivery system, we've been always talking about fee-for-service. Now we're talking about global payments and capitated payments and different models where telehealth is a tool that people use to deliver the health care. And in terms of capacity, I think everyone realizes we don't have enough doctors and other healthcare professionals now, so what can we do to make sure that not just in rural areas, but everywhere have access to competent care, and the healthcare professional does not always have to physically be in the room. So we talked a lot about telehealth and how that combined with team composition of doctors and nurse practitioners can help us have more capacity for the people that we serve in Virginia now, but also the new people seeking insurance under the Affordable Care Act. And obviously, when you talk about technology, telehealth is a tool that just keeps changing as time goes on. I think technology in itself is just wonderful. I'm one of the generation that grew up with one TV in the house that was black and white, and the remote control was us. And so, think how far we've come now, just on television. So, basically, we've been trying to do whatever we can in Virginia to break down barriers for telehealth. And so I know that you all have already had several conversations about what works and what are some of the barriers. And through Karen, I'm sure she will work with us to tell us what we can do, which is in our control at the state level. Because everyone, the governor and the secretary, are very pro telehealth in terms of making sure that we have the best cost-effective quality delivery system in Virginia. Now, as far as Medicaid is concerned, we've always been interested in telehealth too, and it kind of coincides with all the work that Karen's been doing, because she's been in Virginia since. I'm going to fast forward through a lot of these things because it's just kind of background, but as you look at our Virginia Medicaid program, we started in 1995, which coincides when Karen Rheuban was in Virginia. So, that's why we call her the Mother Teresa of telehealth. Just as a matter of background, we serve almost 1 million people in the Medicaid program in Virginia at a budget of near $8 billion. We started embracing, telemedicine in 1995. I guess that's when Al Gore, invented the internet at the same time, and just think how much we've gone since then. And it was a small pilot, a small number of services, and it wasn't until 2003 that we started, branching out. I think basically as telehealth has evolved, it's kind of like, okay, now we need to consider that. And I think what you'll see over time, and what you all have been talking about, we've always been talking about it as a fee-for-service thing where you have to put another modifier on the claim to make sure you're doing telehealth. And I think as we've moved to managed care in Virginia, where 70% of Medicaid is in managed care, it's all under the global payment. We expect people to do what they need to do to take care of the client. So in 2003, we did add the list of services that you see there. And that was a major movement forward. And then we added what kind of providers that we recognize in Virginia. And the other thing I'd say to my counterparts in other states who may not have embraced telemedicine for Medicaid yet is, generally in a Medicaid arena, when something new comes up, we have to price out for the governor and the General Assembly, how much is this going to cost? And people think, well, telemedicine is going to cost more. But it's not a new service, it's a method of delivering services. So that's how Virginia has embraced it and has convinced the General Assembly and the governor that, no, this isn't a new service you have to price out. This is just another mechanism to make sure we provide access to our clients. Obviously, in October 2009, we expanded where the originating sites were. And again, you can see it's just an evolution. Somebody goes, hey, you need to allow it in your PACE programs, the Program of All-Inclusive Care for the Elderly. That makes sense because of those of you who might be familiar with those programs, that's where we combine Medicare and Medicaid and provide all the services an elderly person needs centered around adult day health care. Under fee-for-service, we do have billing procedures for fee-for-service, but Virginia is moving further and further away from fee-for-service. We're now 70% managed care, and I said as it moves into different payment systems, the code isn't as important. And obviously with telemedicine, and if it's specific providers to telemedicine, we expect them to fully comply with service documentation and billing requirements. And when we do audits, the extent that a telemedicine is used, we're going to audit for those types of things. But the good thing that we were able to do was not to follow the definition of Medicare coverage and tie it to rural area definitions. Even though it tends to be used in rural areas, I think all of us realize that even in urban areas, this is a very useful method of getting services. So recently we've added some new services, and these are things that were brought up in the larger arena that commercial as well as Medicaid should provide it. When we talk about health care reform, having a dividing line that commercial provides certain things and Medicaid might not provide that, doesn't make sense for us. We do a lot of comparisons of what we're going to do based on what's already out there in the commercial area. So we've added I'm not going to try to list all these things, but you can see that we keep adding things as it relates to eyesight, dermatology, speech therapy, all the things that you all know is important and is valuable with telehealth. And this slide really doesn't say much except that in our fee-for-service program, we haven't gotten lots of utilization if you just look at claims. But if you look at the next slide, it kind of says, some providers are not using the billing modifiers, some are part of a larger bundle of services, and then a lot of the hospitals and clinics don't break it out. You get paid, it's just not broken out on the claim. And we now have 6 managed care plans, but we've had 5 for years. And we surveyed each of the 5 managed care plans, because what we do is we say, we promote telemedicine, and these are the things we cover in the fee-for-service program. So at the very least, you have to do that in your program, but they also use the fact that they have a capitated payment to go further than that. And so in the next couple of slides, it's just an example of how they've used managed care, and especially for adolescents and psychiatric services, they've used one managed care organization use it. You can see that another managed care has over 51 telemedicine presentation sites. You can see that a third is starting to move better in that direction by working with Karen Rheuban at the University of Virginia. And then a fourth one has talked about that their encounters are focused on the age blind and disabled. And then another one makes sure that telemedicine is available to all of them and doesn't require pre-authorization. And what we just did in Virginia, if you know the state of Virginia, the far southwest of Virginia hasn't had managed care, and we just went there on July 1st. And obviously, if you look at the map, something looks like it only takes 10 minutes, but when you actually drive it, it takes 45 minutes to an hour around the mountains. And so telemedicine has been very important as we move in that area. We're still talking about several things that we think will move the ball forward, such as adding home health services to telemedicine. We're looking at how it will help somebody who has just gotten out of surgery, high-risk pregnancies, and infections. We're looking at the store and forward coverage, and as I mentioned, that's particularly important for ophthalmology. We just met last week on some of the things Karen has asked us to look at, because I have different people who give me their wish list on a regular basis, and Karen's one of those, and we're always happy to accommodate her. But we're working on a Medicaid memo that will deal with the out-of-state physicians and how they can receive reimbursement under Virginia Medicaid. But, unfortunately, can't just do the memo. There's some systems issues, so that probably will not occur to the end of this year. And my staff put in that model, this cartoon You guys might understand it. I didn't, but I couldn't delete it while I was driving. So thank you.
So I'm going to give telehealth perspective from the state of Maryland, and like Virginia, we're very similar in the number of people that we serve in our budgets, but unlike Virginia, we're very late to the telehealth party. And we really only started looking at this in 2010 as part of the Maryland Health Quality and Cost Council, which is a council in the state of Maryland that's chaired by the Lieutenant Governor and the Secretary of Health. And this is one of the initiatives that the Quality and Cost Council took on to look at not only access, but certainly quality of care and the cost implications. The committee was tasked with identifying challenges and solutions to advance telehealth in Maryland, and they came up with a report that was then advanced to the next level by putting together a task force to look even deeper into what the initial report did. It was led by the Maryland Healthcare Commission, as well as the Maryland Institute for Emergency Medical Services. And basically 3 advisory groups were established to develop formal recommendations. And these are the 3 groups: Financial and Business Model Advisory Group, Technology Solutions and Standards, and Clinical Advisory Group. The Finance and Business Model Group recommended that the state-regulated payers to reimburse for telemedicine services to the same extent as healthcare services, providing face-to-face. The Technology Solutions and Standards Advisory Group wanted a network built on existing standards integrated in the statewide health information exchange, which now has all 46 hospitals reporting regularly discharge data, lab data, radiology data. So they wanted this integrated into our statewide information exchange. And that at a minimum, there should be requirements related to technology and connectivity. And then the Clinical Advisory Group, which really centered around licensure, credentialing, and privileging of providers. So from the Finance and Business Model Advisory Group came legislation that was introduced this session. And there was a House bill and a Senate bill that were both introduced that basically said that state-regulated private payers and Medicaid needed to cover cover healthcare services delivered through telehealth as they would in person. Private payers were not permitted to require pre-authorization for telehealth services. They also were not required or could not limit to just rural areas. So the department supported the bill, but supported the bill with amendments, specifically that would allow Medicaid to conduct a review. And unlike other health departments in the state of Maryland, Medicaid sits in the Department of Health and Mental Hygiene. In other states, Medicaid sits in the Department of Social Services. So we supported the bill, but we really wanted to understand what the implications were to the system, and basically responded that we supported, but we needed to see if it was cost neutral, and if it was, that we would cover, this is a typo, in fiscal year 13, but if they were not cost neutral, that we would seek coverage in 14 and work with the budget and the General Assembly in 2013 to get it covered. So we wanted to allow private payers to require pre-authorization for telehealth services. And the bill passed and signed into law with the amendments that Medicaid was allowed to do a further analysis on the impact to the system. So pursuant to cost-neutral language, we started conducting a review of the literature and evidence on telehealth. And we did a pretty comprehensive analysis, at least of information that was publicly available, as well as using the network available to Medicaid directors to understand what was being covered. And what we found were that 37 states were covering hub-and-spoke teleconferencing, 16 states were covering store and forward technologies, 15 states covered home health monitoring, and only 2 states covered telephone and email. So with that, we started framing out, well, what would we cover? And in addition to what we found in the states, we also looked to the private payers in the state of Maryland, both commercial and the managed care organizations. We started researching the different modalities and specific services, not only by Medicaid, but as I said, the private payers, as well as looking at any cost studies. Were there any specific modalities that stood out? And we were doing this all in keeping in mind about Maryland's efforts around implementation of the Affordable Care Act. We have lots of things happening in the state, not only on patient-centered medical homes, but accountable care organizations, and trying to keep that in mind. Maryland just got funded for 4 ACOs in the state of Maryland, and 3 of those 4 ACOs are practicing in rural areas. So we've been synthesizing the research findings and working with Hilltop, who houses the Medicaid data in the state of Maryland at UMBC, developing the assumptions based on what we found on the other states, based on Affordable Care Act implementation that's happening in the state, and based on what private payers are doing. We did, prior to all this happening, cover telemental health services, but our originating site could only come from an outpatient mental health service, a hospital, and or a federally qualified health center, and the distant provider could only be a psychiatrist, and it was limited to 12 rural counties. So in addition to what we're doing now to expand our coverage, we're also reassessing telemental health utilization and looking to expand that further. I can tell you, based on our analysis, we are including everything in the assumptions, from real-time interface to store and forward technology, and especially home health monitoring, especially as we think about our long-term care rebalancing efforts that are happening in the state. We think that's going to be key. So we have to report back to the General Assembly in December. I think most of our analysis will be done in the next couple of months. Thank you.
Good afternoon, everyone. It's a real pleasure to be with you today. And before I start talking about the little state of Delaware, unlike the bigger states of Maryland and Virginia, does everybody know where Delaware is? We are not a county of Pennsylvania. We are actually a state. We have less than 1 million in our population. The governor likes to call us a state of neighbors because we do indeed know everyone in the state of Delaware. But before I go into more details about where we are, I would like to applaud the efforts of Dr. Rheuban. It was really through her passion and her advocacy that Delaware actually started to advance our telehealth efforts. And I really need to say that because we were actually not that far along. We were nowhere near where Virginia is, and we're not that far ahead of even where Maryland is. And Dr. Rheuban came to visit our state in 2011 and gave a presentation that I happened to be present at, and it just really excelled the interest and the energy around telehealth. So my gratitude goes to her for being such an ambassador and so passionate about what telehealth can do to advance better health outcomes for our population. Now, I want to talk a little bit about that momentum. After Dr. Rheuban met with all of us in Delaware, we actually created a telehealth coalition that was formed. It now has expanded to over 50 members, including our hospitals. Now, for larger states, that doesn't sound like much, but for the state of Delaware, we actually have 3 counties in our state. Our Newcastle County is our cosmopolitan county. Then we have Dover, and then we have Sussex. Have any of you visited Sussex County? It's known as for its resort area. We're in the resort area. However, it's probably our largest county from a geography standpoint, and it's actually very rural. So when you get in our Kent and Sussex County, it's largely built on agriculture, very open space, but people are spread across those counties. We are also concerned about those counties largely because of the challenges from a medical infrastructure basis. And when we also look primarily at Sussex County, It is the county where we are finding many retirees are actually migrating to Sussex County, actually from the Washington, D.C. area. And what concerns me about that is what I said relative to our medical infrastructure. It is not keeping up with the pace of that demographic. So when we think of telemedicine and telehealth, that really presents itself a marvelous opportunity for us to advance our medical infrastructure through that technology. Now, the Department of Health and Social Services is home to the Medicaid program, and Delaware Medicaid actually began reimbursing for telemedicine, which we started July 1st, 2012 of this year. That is the start of our fiscal year. We did this as a policy. We did not go through our General Assembly. We actually evaluated this in concert with our telehealth coalition, and then we were able to actually advance that as a policy-driven. Largely, Delaware is now largely supported in Medicaid through our managed care organizations who have contracts with numerous providers, and now they are all able to offer telemedicine. Thank you. Wow, I'm coming down here more often. And in conjunction with that, a Delaware hospital and the Department of Health and Social Services are specifically utilizing telepsychiatry for crisis evaluation. And that, again, is in our Sussex County area where I indicated that the infrastructure is very, very much stretched. So we were able to offer that telepsychiatry. We have a much more robust system, actually, in Newcastle County for psychiatric services, and we didn't want to transport people, even though we're a small state, we can travel it within 2.5 hours in either direction. It still would not serve that population, and nor us from a cost-benefit perspective, to put people in cars and travel to Newcastle County to access that service. So we now do that through telepsychiatry. A hospital in Sussex County partners now actually with a hospital in Newcastle County, Christiana Care Health Systems, which is our largest medical provider, for teleconsulting services on trauma cases. Otherwise, again, those patients who are traumatized either by an accident or injury would have to travel, take the helicopter from Sussex County to Newcastle County for a trauma evaluation. Now it's very safe to keep them in that hospital in Sussex County, and in partnership with Christiana Care, who has a much more robust system of care, they're able to connect those dots as well. So we believe that through the telehealth that we are really advancing better care for all Delawareans, regardless of what county you may reside in. We are also working with our federally qualified healthcare centers. Lared Health Center is also in Sussex County and Georgetown, and they received a Rural Health Services Outreach Grant to provide telepsychiatry, and they're actually interested in advancing beyond just the psychiatric support. Now, I must tell you, in addition to Dr. Rheuban, we had a tremendous advocate in the state. And coming from an organization like AARP, actually my history has been in advocacy. The one that always tried to influence government from the outside finds herself trying to influence herself from the inside. But really, it's the ground that makes the difference. It's that pressure point from the ground. Government many times is not that quick to advance. Multiple issues that impact the government. So you really look to that squeaky wheel on the outside. And Dennis Liebel actually came from Washington, D.C., one of those retirees that landed in Lewis, Delaware. His wife, Betty, was diagnosed with Parkinson's disease 10 years ago. And in 2008, they retired from College Park, Maryland, and actually had a second home in Lewis, and now they call Lewis their home. In 2009, through his advocacy efforts, he founded a support group of 150 individuals to support these individuals with Parkinson's, because he found many retirees were faced with this devastating disease and were looking for care. And as I said, Sussex County does not have that robust medical support system. So many support group members actually were seeing their specialist in Washington or Baltimore or even Philadelphia, and it was a difficult round trip to see those doctors, especially if you are suffering from Parkinson's disease. So Dennis Liebel actually met with me early on. I was appointed in 2009 and came to me and introduced me actually to Dr. Dorsey, who is at Johns Hopkins. He's a neurologist, and he was supporting many of the individuals from Sussex County, who again would have to travel to Baltimore to see their specialist. And so what we are doing now is we're working with Lored, our federally qualified healthcare center, and Dr. Dorsey to bring that telehealth to Sussex County with a specific interest in supporting those individuals from Sussex County who are suffering from Parkinson's disease. So they no longer have to do that round trip and travel, which actually, for many of them, would take them 2 days, and then to recover from that travel. Not a good way to actually promote good health care for those individuals. And I credit, Dennis Liebel, but also Dr. Dorsey, who has just been phenomenal with trying to support this in our state. And Dennis Liebel, effectively says, put yourself in our shoes. It's a 3-hour drive up there, getting parked half an hour, waiting half an hour. You do get an hour appointment, but it's a 10 to 12 hour day. And again, that is not the best way to deliver health care for people who are suffering from any type of disease. The other issue, as I said earlier, relative to the retirees, again, we're seeing this throughout the state of Delaware with a specific spike in Sussex County. Delaware seems to be aging at a faster rate than any other state in the nation. Actually, and I can attest to that personally, we are ninth in states. And a lot of that has to do, I'm a native Delawarean, so I would tell you a lot of that has to do with the beauty of our state. I think it's fabulous. But it also has to do with our tax base. And so people are migrating. Along with that, we know that people who are aging also present some health issues. The body does tend to wear down even when we take very good care of it. So because of that, we know that we will be impacted, and again, in our lowermost county. So it only made sense for us to really start trying to get ahead of that paradigm shift and really looking at, in the most cost-efficient, effective way, how can we connect people to health care, regardless if it's the best professionals that we have within our state or if we can expand beyond our state and connect people so that we can promote the best health outcomes possible, regardless of your age or if you have disability. Now, that doesn't come without barriers. And here's some of the barriers that we find ourselves that the coalition continues to dedicate energy and effort to address. Distant site providers must be licensed in Delaware. I must tell you, to get a license in Delaware is not the easiest thing to go through. So what I've done, and that's not within my Department of Health and Social Services, it's actually in a sister department called our Secretary of State. But what I did with one of my chief medical positions is I dedicated that position to the Office of the Secretary within my department. And Dr. Gallucci is working hand in hand with the Secretary of State to streamline that process, because we do in Delaware have a serious workforce development issue. So we want to get people, we've lost people through the licensing process, and we don't want that to happen. That is not in the best interest of Delawareans. So I've dedicated a position to actually work closely with our sister organization to look at how do we streamline that process and address this issue. The technology has not been widely adopted. I'm sorry to say I got to bring Dr. Rheuban back in the state and get her on the bully pulpit, because she's very effective in doing that. Some people are very skeptical, so hopefully now with the Medicaid reimbursement, we can actually show evidence of, good outcomes, that the cost isn't prohibitive, and really advance this throughout our whole system. Many patients aren't necessarily comfortable seeing a provider this way. I must tell you, though, when they have to drive 3 hours to see one, they're going to get pretty comfortable pretty quick. And many of our individuals, again, are in the rural areas of Delaware, and they have different, I could start talking about transportation in rural areas, which is also extremely challenged. So for people who had nothing, this will be a tremendous gift for them. And hospitals and practitioners see it as a threat to the revenue streams. However, if it's reimbursable, they won't see it as a threat. They'll see it as an advancement of their ability to serve a population. So what's next for Delaware? We are bringing more hospitals and primary care doctors now into our coalition. The coalition was strictly a lot of the grassroots, the advocates, it was the state. Now we have to also branch out to the private sector. This will be a collaboration. And with collaboration brings cooperation, so that we will be, working together. And again, the hospitals are indeed coming on board. We're looking at applications, including at-home uses for Delaware's aging population and the state's underserved rural areas. I think actually they will be the pioneers. And then once we can indeed use that data, evidence-based practices, that we will be able to even advance this in our cosmopolitan area. We are creating a website for the coalition, so more will come from that. People then can get access to that website with additional information. I believe also brings additional advancement. And what we want to do at stateside is to begin utilizing telehealth as a means to manage our chronic care conditions as supported by the Affordable Care Act. So thank you very much for spending time with me today, and come visit us in Delaware.
Thank you, everyone. I'm Maurita, Coley, Chief Operating Officer of Minority Media and Telecommunications Council, and I'm very pleased to be here today representing the National Organization of Black Elected Legislative Women, also known as the Nobel Women or Noble Women. They are indeed noble as well. MMTC, if I can talk about our organization first, we've been around for about 25 years. We're a leader in media and telecommunications policy and advocacy for minorities and underserved communities. We started out advocating for minority ownership and diversity of voices in the media, and then we've expanded into broadband adoption and advocacy and telecommunications policies that are designed to deal with issues with the people who don't necessarily have the iPods, the iPads, the 3 or 4 smartphones in their pockets like some of our colleagues. We have worked with the Nobel Women We've worked with the Nobel Women on a number of proceedings before the FCC, such as the Open Internet proceeding, universal service reform, lifeline service, any kind of issues dealing with low-income families. We've been very active with the National Broadband Plan and broadband adoption, and also with minority media ownership policies. Our chair, Julia Johnson, who I'm standing in for today, is an advisor to Nobel Women on telecommunications policy issues, and the Nobel president, Senator Sharon Weston Broome of Louisiana, serves on our advisory board. So it's not exactly interlocking directorates, but in some ways it is. It's a good a collaboration that we have with the Nobel Women. We publish white papers. If you look on either of our websites, you'll see white papers on broadband adoption, on minorities in the high-tech area. We tweet each other's stuff. We comment on each other's stuff and just collaborate to try to get information out that is directed toward underserved communities. We've partnered on a number of regulatory and legislative policy events. I think there's been a lot of discussion about the National Broadband Plan. I've been watching from the webcast yesterday and today. And so we've worked on that to try to achieve 98% broadband adoption by 2015, as our president wants us to do, and also to create jobs and business opportunities for small and minority-owned businesses. We work in the areas of spectrum exhaust. We work both with Nobel and on our own in spectrum exhaust. and on wireless and smartphone adoption. The way that we look at telemedicine is we believe that telemedicine is actually a, excuse the perhaps overuse of the word, game changer for the underserved communities. And this is in both urban areas and rural areas, because in the underserved area, there is actually not that big of a difference between the underserved communities in rural and urban. A lot of the disparities come from a lack of access or a lack of representation of whatever it may be, from grocery stores to, on the food desert side, to healthcare practitioners on the health side. So, in a lot of ways, urban and rural have converged in this area because we have a lot of things in common. Just to tell you a little bit in detail about the Nobel women, they are a mighty group of 255 members of state legislators, both current and former, in 39 states, and they work to communicate the legal, social, political, economic, and health needs of children, women, and families. And we work with Nobel and advocate on behalf of issues in telecommunications at the local, state, and federal levels. And at the White House, the Federal Communications Commission, the Federal Trade Commission, the House, and the Senate. What we want to talk about today is Nobel's model telemedicine legislation, which was launched actually last year, but a formal launch occurred last month here in Washington. And if I can give Karen, Dr. Rheuban, a shout out, she has been an advisor to Nobel and indirectly to MMTC as we're learning telecommunications, telemedicine along with Nobel women. But it is an opportunity, I think, for a widespread adoption of telemedicine. You see where my mind is, 25 years in telecommunications. There's an opportunity for widespread advocacy in telemedicine, much as what we've already done in broadband adoption. And on the model legislation is primarily the same as the American Telemedicine Association's legislation, in that it's focused on trying to require private pay mandates to be the same for in-person as telemedicine coverage. But what the Nobel women do is really also focus on extending state Medicaid coverage in their telemedicine legislation. The highlights of Nobel women's model telemedicine legislation is to require the coverage of telemedicine, to expand the definition, or in some cases define telemedicine to include audio, video, and other telecommunications technology at a site other than where the patient is located, to allow home telehealth via video conferencing or remote patient monitoring, to require that any denials of coverages be subject to review procedures, and that Medicaid plans can't deny coverage if they would cover it in an in-person consultation. It would require statewide medical assistance benefits to the health home for individuals with chronic conditions. That is something that Nobel in particular has taken up because of their interest in serving women and families, is that there are a lot of chronic conditions within minority communities that they're over-indexing in heart disease and diabetes. 20% of African Americans over 30 are being diagnosed with diabetes, and there are just a whole host of problems in minority and underserved communities that can be addressed, we think, through telemedicine. One of the other big things that Nobel is really interested in is trying to deal with the 56 million Americans, many of whom are minorities and racial and ethnic minorities or rural Americans, who are without a primary care physician. And I just can't even imagine that, because I feel like, for the years that I've been in Washington, my primary care physician and I are on a first name basis, and I can even remember calling her when I was on vacation, for an emergency. And it's hard for some of us to imagine this, but a lot of people don't have access to a primary care physician. I live in an area of Washington that doesn't have any, that I've seen, doctor's offices, and that is primarily composed of the urgent care. And it's great to have the urgent care providers there, but there are a lot of urgent care providers and nighttime pediatrics types of providers. So it's an issue that's really important that often, I think, when we work in the policy areas, we don't really recognize, because we may not live in the areas where there are the food and medical care deserts. But this is something that Nobel is very much interested in, trying to deal with those kinds of disparities and try to bridge some of the health care gaps. We believe that telemedicine is an absolute game changer, and it's absolutely critical to bridging the primary care gap. Some of the gaps are caused by financial issues, transportation, and we're talking about both personal transportation and public transportation barriers, along with the insufficient primary care resources. And again, this is something that is current, it exists in both rural areas and urban areas, and have the same kinds of issues. Most states provide some Medicaid coverage of telemedicine, but this varies widely, and one of the things that Nobel wants to do is to work on establishing equal, a level playing field in terms of telemedicine legislation. So last month, the big launch, with the help of Karen and a number of other advisors, Nobel decided that we're going to expand telemedicine legislation to every state where there is a Nobel women. Currently, that means 39 states, but it's growing every day as Nobel women are being elected and getting more involved in solving the issues in their communities. It's a great thing to watch. So the telemedicine group action plan is going to be an extensive action plan for each state. One of the things that we've noticed is that in many cases, telemedicine is already covered, and it's something that's a matter of bringing the legislation to the attention of the state Secretary of Health and helping to work on the ground to get the state secretaries of health to clarify that telemedicine is covered, for instance, in the definition of physician services. Nobel is going to drive the model legislation on a state-by-state basis, hosting roundtables, being on panels to increase the awareness of telehealth, identifying key stakeholder organizations and groups for partnering and for collaborating with. And this will be done on both a federal and a state basis. The overall strategy on the state side is going to look at things like the health home for chronic care, high-risk pregnancies, stroke diagnosis and rehabilitation, the patient monitoring for chronic care, mental health counseling, school-based health services such as for speech and hearing, Medicare-level telehealth coverage for rural and medically underserved areas, safety net critical access facilities, and also looking into telehealth coverage for state employees. Then the Nobel strategy on the federal level will be advocating for federal legislation for improving Medicare coverage for urban beneficiaries, home-based services, store and forward kinds of telehealth in both the urban and rural areas, telehealth payment and service models for dually eligible patients, working with the Federal Communications Commission on rural health programs to enable wider broadband access, and nationwide portability for healthcare professional licenses, which brings us to the issue of another issue related to this that Nobel has gotten involved in is the licensure of practitioners. Telehealth licensure resolution, Nobel's telehealth licensure resolution was passed on June 22nd at their legislative summit in Baltimore. And basically, this is what you've been hearing about for the past couple of days, this sort of need for a framework so that doctors and medical providers don't have to get a different license in every state in which the patient is located if they're doing telemedicine. We celebrate with Laura Herrera here in Maryland, Victory in Maryland. 2 Nobel women were actively involved in passage of the Maryland telemedicine legislation. Senator Catherine Pugh and Delegate Susan Lee, both women of color, were very actively involved in getting the Maryland legislation through. It was signed on May 22nd, and I guess I don't need to go into that because we have a real-life Maryland representative here. But we're looking forward to basically taking the package, the model legislation, and our representation in almost all 50 states, but just basically taking that show on the road, getting involved with those of you in the room, those of you who are involved in coalitions in other states, and basically looking at it as you don't have to reinvent the wheel. We're already prepared. We already have representatives in the legislature, but it's something that the Nobel women can't do alone. It's something that we'll have to do in collaboration with those of us who are in the room and those who aren't in the room. So we'll continue to go from state to state and, down the street on the Hill because we will be involved in both federal advocacy with the Federal Communications Commissioners. We've already gotten Commissioner Mignon Clyburn involved in supporting this effort, and also on the state advocacy with community advocates and policymakers, and then on the media side with press releases, media placements. Both Politic 365 is a media placement that we use on a regular basis, and also MMTC's Broadband and Social Justice Journal, the Huffington Post, and just a number of other areas where we plan to have for 2013 a full-scale national campaign for telemedicine, and we would love to have everyone in this room and on the web involved with us. Thank you.
Thanks to each of our panelists. I would say, Cindi, you have been such an advocate at the state level, and Laura, great things are coming in Maryland, and Secretary Landgraf, you've made Delaware the little engine that could, absolutely, and Maurita, the group for the Nobel Women have been fantastic, and MMTC as well. And I want to also add Julia Johnson serves on the ATA board, so we are very cross-fertilized in terms of advancing our missions together. So I'd love to open up for the floor for questions of our panelists about how we can advance further at the state level. Stuart?
So I just want to congratulate you guys. You guys are just a powerful force. It's great what you're doing at the state level, and Karen, it's great what you do to assist them and to help on the national level. You guys are heroes. On behalf of the folks in telehealth, I think what you've done is spectacular. I work with the American Telemedicine Association. We're working with Nobel Women. And that's just a great effort, and that has so many states kind of under the spotlight right now, and that's a great effort. I have 2 questions, and they're really directed at Maryland and Laura. One is that you're talking about doing a cost neutrality study, and you're doing some work, and I think you're going to have that work done by December. So my first question is, I guess I'd be very interested in learning what you learn in that process, and I guess one of my questions is, will that report be generally available either at the summary or at the detailed level?
Yes. It'll be publicly available once
Perfect.
It's released to the General Assembly, and it will be pretty detailed, not only having looked at all 50 states and what they're doing, but what the literature, what the VA, Indian Health Services, we're looking at everyone.
Fantastic. Okay, and then my second question, still for you, is you had one sentence in one of your slides where you talked about you would be requiring telehealth to be integrated with your health information exchange. And I was curious if you could explain kind of what the intent and what the desired functionality of that would be.
Well, to the point about just the record keeping of the telehealth encounter and that being incorporated into the patient's record the way we're trying to include all the other records. Right now we're getting information from hospitals, but we're ultimately looking to expand that around at least the 4 accountable care organizations in our patient-centered medical homes. So any telehealth encounters that would happen under those umbrellas, for lack of a better description, we want that data also included in the health information exchange.
Great, thank you. Thank you very much. And again, congratulations. You guys are amazing.
Also, as we talk about the value proposition for the Medicaid programs, and I guess each state is different in terms of looking at that value proposition. I know Virginia Medicaid for years and years spent millions and millions and millions of dollars on transportation costs. And is Maryland going to be looking at that cost savings as part of the value proposition as well?
So we're definitely looking at cost savings, and again, back to Affordable Care Act. There are lots of initiatives around ED utilization and hospital admission and 30-day readmission. So even preventing those access points in the healthcare system, those will be built into. Again, we're developing the list of assumptions, and then Hilltop at UMBC will actually be doing the modeling. But we're looking for everything. We're not just limiting ourselves to real-time interface. We're also looking, costing out, store and forward, as well as home health monitoring. And we think especially the latter with our long-term care rebalancing efforts, that's going to be key to how that all plays out.
Thanks. Hi, I'm Nina Antonetti. I'm the Director of Telehealth Business at Marshfield Clinic in Wisconsin. And I just really need to reiterate Stu's comments. You 4 ladies are amazing. Just in your vision and your actionable presence. And, I feel like I can go and change the world. And people always ask me to go and change the world because I'm usually described that way. So thank you for being mentors to all of us. I have 2 questions. And I think it's Secretary Landgraf. One of the slides you had was about barriers, and yesterday we heard a lot of assumptions that public policy is built upon, and that just drives us crazy because we know different, those of us out here doing the work. So I just was wondering, because those barriers, I don't see those barriers in my program or in many of the programs I work with to get started. So I'm wondering what, not that I'm questioning it, but what evidence was there that led that to be on your list of barriers? And then my other question is for Ms. Coley. How can we get involved with Nobel Women and help you do what you are doing, even if it's not our state? We have good reimbursement in Wisconsin because the state came to me and said, can you write our reimbursement policy? So, of course, I did that as broadly as I could. But I would love to be engaged somehow with your organization and really helping you get the work done that needs to be done. Thank you.
Thank you for your question. Relative to the barriers, that actually came out as part of the work of the coalition. So it actually came out through the grassroots that they were identifying that to me as the secretary that, here we're trying to advance, but here's some significant barriers. And again, the licensure issue for the doctors was one that came up as a highlighted one, and that's the one that we're right now really kind of focused on, so how we could advance that. The other ones, again, it's interesting because the technology is the gateway, is the access, for, especially when I think of Delaware, because we are very stretched from a workforce development perspective. And so some people just are very threatened by this use of technology. Some people within the medical field are very threatened by this technology. We even had to get to the point, the usage of nurse practitioners because we don't have primary care physicians, but even trying to advance that, people were threatened by it. So some of it, I believe, is really a mindset, not necessarily policy driven. And we have a body that's called our Healthcare Commission in the state of Delaware. I'm a commissioner on that, but it's made up of both the the public sector and the private sector. And we open that, and the public is very, very engaged. So we also use that vehicle to really educate the public on these issues, because most of it, I think, are myths, but somehow they've become factual. So how do you dispel those myths is that you have to really concentrate and educate. And for whatever reason, the use of telehealth, people think it's actually dumbing down medicine, and it really isn't. It just affords additional access to some of the best medicine that is out there. So that's where those barriers, but we're very committed to, really engaging a broader stakeholder network to cut across those barriers. And I did say something that Medicaid was able to do this by policy, but I also believe strongly that we need to codify this as a legislative issue, as a state law, because this administration came in and said it was something we wanted to advance, but under policy, anybody can come in and take that away. So I really believe, with the advancement of healthcare reform and the Affordable Care Act, that it does need to be codified.
You have 2 Nobel women I know that are interested in doing that in your state.
And I, on behalf of Nobel Women, I thank you for asking that question, first of all, because it gives us an opportunity. First of all, if anyone here is interested, you can look at the Nobel Women site, nobel-women.org, and you can look at a lot of the work that's being done. We do have representatives in Wisconsin, and we have a whole strategy that we can help put together in your state. And Karen was very active in the strategy in Maryland, which I understood. I wasn't involved in it, but I understand that it just went phenomenally well with Senator Pugh and Representative Lee, basically, taking the package and, working it through the legislature. So we're interested in partnering with anyone who is in the states and who's interested in this area, particularly because the Nobel Women are concerned about these issues as they impact families and women, and a number of women in the position of being heads of household. So you can look at us on our website, and I also can give you my personal information to connect you. So thank you.
Hi, my name is Amy Shoup, and I'm from UNC Chapel Hill. North Carolina is just beginning to move forward in a collaborative fashion to advance telehealth, not just on our local level, but on a state level. And so I really appreciate you ladies being so informative, because now I know where to get information that we so necessarily need. But my question, while we are trying to serve, or we wish to serve, rural communities, minority communities, aging communities, reach chronic disease populations, we're also looking at other populations, such as the Department of Corrections. And I wanted to know if that is something that you have also rolled out in addition to the populations you spoke about today, and if you have cost recovery models or cost saving models that would be able to be shared.
I can certainly comment. In the Commonwealth of Virginia, the correctional telehealth is a very large element of healthcare service delivery to Virginia prisoners, and that is not managed by Cindi, but managed by a different secretariat I don't even know the name of that secretariat, but that's where healthcare is managed, and it's done. And there are correctional telemedicine programs around the country, and certainly our correctional patients deserve high-quality care as well, and it's been a very successful tool. My colleagues at Virginia Commonwealth University provide a lot of those services. I know in Texas there's a very large correctional telehealth program, so there are models there that we'd be all happy to share. And of course they pay for transportation and security for patients who are traveling.
Lisa Killowy from Avera Health in South Dakota, and my question, Stuart asked my first 2 questions, and I really look forward to the Medicaid data with the state survey that you did. But my other question to add on to his would be, do you foresee developing plans to engage with providers to develop more interest to get the usage and the providing of telemedicine services up? You mentioned that the numbers are pretty low.
So there are actually the two large academic institutions in Baltimore City, Johns Hopkins and University of Maryland, are already doing a fair amount of telehealth and have their own actually telehealth departments, and they are very much engaged in all these different advisory committees and providing subject matter expertise from, equipment to standards of care, and I think they've been working with ATA on some of those standards as well. So this wasn't just done by the department. There were lots of people engaged in this process to get us to where we are now, and it's those same people that were engaged in the original task force and then as part of the Quality and Cost Council that continue to move the initiative forward. So education and training will be part of that once either Medicaid says we're going to go forward, educating our MCO providers and the MCOs in general. But that's certainly built into the strategic plan to move telehealth forward in Maryland.
Okay, great. Thank you.
Hi, John Allen, like Chuck from NASA headquarters here in Washington. Excellent presentations, all of you, and I would put the question to all of you, particularly on the heels of the last discussion as far as technologies. I think each of you had mentioned some issue with respect to embracing technologies and or access to technologies. One of the concerns I always fall back in that area is as we're dealing with whether it's the underserved populations, whether it's rural populations, however you want to characterize those. One of our colleagues that worked with us for many years was a physician from Australia who led the medical expeditions to Antarctica for decades. And his emphasis as he looked at telemedicine is telemedicine has been around ever since medicine's been around, essentially. It's sort of the way you go about doing that. And that he saw in many cases, again, folks wanting to bring in sophisticated technologies into very remote and austere environments and then having either technology failures or, again, a failure to embrace or lack of training, et cetera. So I wonder, are you dealing with these embracement issues or technology, bringing the right technologies in on a stepwise fashion of saying, do you have a phone? Can you utilize the telephone? Because certainly that, I think all of us are accustomed to that, not terribly fearful of telephones, whether they're dumb phones. Smartphones may be a little intimidating, but whether there isn't a stepwise fashion to then bring people into the environment, even though it's not the latest and most sophisticated technology.
Well, in Virginia, I think, one of the things we do is we get carried away with technology and we don't step back and realize that there are some significant areas of the state that can't get the internet. And so what we did, our Secretary of Technology did a comprehensive surveys of all the healthcare providers in Virginia to find out what their capabilities were, not just for telehealth, but for the electronic health records that we were talking about. And we found some significant black holes, and now there's the push to try to provide fund to close the black holes for as far as the internet is concerned, but also to provide funding to get people up to where they need to be in order to communicate electronically.
On a personal level, I was saying this earlier, I volunteered with Indian Health Services years and years ago, and so I was in Alaska north of the Arctic Circle using telehealth equipment, more than 14 years ago, so I thought it was incredible in action, and now to be in a state where we hardly have any telehealth, it's hard to kind of get people engaged. To the point about, even something as basic as the phone, I think reimbursement is going to be the issue. And I think it was said earlier in the last panel, providers want to do all they can to deliver, to one, be accessible, and two, deliver quality care. But if they're not reimbursed for it, with all the competing priorities of a clinician's time, it's just not going to happen. So I think we're certainly looking to these other technologies if there's a way to reimburse for using something other than the three big groups that we typically think of. So.
And I think Laura brings up a great point about the reimbursement, because if you think about, the sustainability, you're going to need that reimbursement component. And I think we also have to think creatively relative to these barriers. Maybe people won't be able to access within their home in a given time, but then can we work with the retail market? I know that, some of the pharmacies want to be able to provide this as some level of service, or at least to be able to get that level of access. So, I think the more that there's a coalition and the more engagement between the private and the public sector, I think the reality of this is quite feasible. I mean, there was a one time, history keeps repeating itself. It just maybe gets more sophisticated along the way, because now we're talking about patient-centered medical homes. Well, it used to be the norm that primary care physicians did home visits. That's coming back again. It can come back by person to person, or it can come back through telehealth.
And that is what your question hits directly on, the kind of advocacy work that Nobel Women and MMTC have been involved in over the past several years, because we've gone out really big on broadband adoption, because what we learned is that a lot of approximately 35% of women are non-high-speed internet. They don't have high-speed internet at home. The same thing with minorities. There's a lot of overlapping in that in terms of income, gender, ethnicity, and there are all these studies that were done that we dealt with the whole issue of pay. So the FCC has worked on that in terms of the Universal Service Fund and making it available for high-speed internet and not just for, landline telephone. We've worked on the whole issue of providing packages so that people can have a low-cost computer, because we found out that was another barrier. Like, people don't have high-speed internet at home because, first of all, you've got to buy it and you can't pay for it, and then you've got to buy a computer. But then one of the things that surfaced with all these studies is that an equal barrier, maybe even a little bit higher of a barrier, is the lack of informed use. People don't understand technology; it's over their heads. They don't know how to use it, and so that your point is very well taken. And I think that's sort of a prerequisite to really rolling out telemedicine the way we might really want to do that. My grandmother's on Skype now, so I figure by the time she's ready for something, then she'll be already ready to see her doctor on TV or on her cell phone or whatever. So thank you.
Thanks. One last question, Bill.
Good afternoon. My name is Bill Applegate, and I'm from the Iowa Chronic Care Consortium. And I'm really was impressed with the presentation too, and how you've advanced things in telemedicine. And I think that the Secretary Landgraf talked a little bit about maybe considering telehome care and some other things. And so maybe this is for you, and maybe for Cindi, who still has 30% that are fee-for-service people or something like that. But the question is, so when you take this telehealth to a new dimension, which is really managing chronic diseases and things like that, one, what are your expectations, and then what kinds of plans do you have for deploying something? Because that's you've had your experience in telemedicine now, so you take this to the next level. What are your expectations, and how would you like that to work?
Well, our experience hasn't been that robust just yet, but I think from the chronic care disease management side of it, we and I actually have an opportunity to meet monthly with my managed care organizations, because they're a significant partner with us under our Medicaid program. And what we've been noticing is the traditional chronic care disease management is not actually producing the outcomes that we really want. So we're looking at, in concert with our MCOs, what can we bring to the table, and really look at who are my high cost drivers, and looking at that data, and then looking at some methodologies that we can put into play and evaluate that actually real time as we're doing it, to see if we are then getting a benefit. And that's where I see the telehealth as playing a significant role in that. So maybe not rolling it out to the whole population initially, but looking at my most high-cost
people that have chronic care disease within my Medicaid population, and then doing pilots to focus on this that I can tweak as I go to develop, access to that through the use of telehealth.
And in Virginia, like many states, the 30% that's outside of managed care are our most costly. They're the people receiving long-term care services as well as behavioral health. We're one of the states that are working with CMS to try to do a dual eligible project. And when we talk about telehealth and how it plays into care coordination for our expensive populations, we always, in the RFP or the contract, describe that we expect, telehealth to be used. What we need to do is kind of step back and say, how directive are we going to be, or do we leave that to the companies that have a lot of experience? And I think we probably need a little bit of both. We don't want to tie people's hands, because as soon as you say you have to do it a certain way, or do, a year, sometimes only 6 months comes and it's changed. So we want to make sure that whatever care coordination umbrella we put over this expensive population, that we allow telehealth to grow naturally and how it should.
All right, well, let's thank our panelists for their vision and passion. It was a great session. We're ready for the next session.